Thank you very much for the introduction. It is a pleasure to be here to discuss a few of the innovations here at Women's College Hospital in our dermatology program. My first exposure to dermatology as a medical student was actually here at Women's College, and I grew up in Calgary, so being from out west, being from out west, Toronto was kind of seen as the evil place, and everyone was asking me, why am I coming out to Toronto to do a rotation? And everyone's mean, and you're not going to have a very good time. They're not very friendly. But I was so impressed with the training here, the mentors, the types of patients that we see, the breadth of exposure, that I came back here to do my residency eventually. And then I left to the U.S. to do a bit more training, and then I came back here to come on as staff. So I've always been very impressed and exposed to Women's College from the very beginning. So the dermatology program was founded almost 70 years ago by a pioneer in women's health and in dermatology, and one of the powerful female physicians early on in Canada. And this was Dr. Ricky Cami Schachter, and our dermatology program is named after her. We see over 50,000 patient appointments every year. This is the largest center in Toronto. It's the largest training program in Canada, and right now we have 32 dermatologists on staff, 12 nurses, and a chiropodist in the wound care center. So today I'll be discussing a couple of the innovations in the dermatology program, focusing on, well, since I'm the speaker, it's my own interest actually, so it's skin cancer and solid organ transplant recipients, and also on the Mohs surgery program, and I'll finish with highlighting some very simple but useful tips for skin health. So if we talk about cancer overall, this is a pie chart depicting how common all the cancers are in Ontario, the various types. You see the most common types are prostate, colorectal, breast, and lung. But if we talk about skin cancer, the numbers of skin cancers add up to all of these top 4 most common types combined. So there's currently an epidemic of skin cancer. It's the most common cancer in humans by far. Fortunately, the majority of the time, if it's caught early, it's readily amenable to treatment. But 1 in 3 Caucasians will develop skin cancer at some point in their life. And the incidence is increasing. Over the last couple of decades, the incidence has doubled. And for some reason, the one group where it seems to be increasing the most is women under the age of 40. And we don't understand entirely all the reasons for that, but it may be related to increased tanning salon use, increased sun exposure. So in Ontario, our best estimates are about 30,000 cases a year. This is likely an underestimate because the cancer registry says that it's too common to record all these, so we don't have the resources. So they actually don't record all skin cancers, which is a strange argument in my mind, since if it's common, it must be a relatively important issue. But as part of my research, our team has actually developed a way to identify and track skin cancers in the province. And so our best estimate is actually more like 50,000 cases a year in Ontario. Now, the minority of these, fortunately, are the dangerous type of skin cancer, melanoma. The vast majority are the less dangerous basal cell and squamous cell carcinomas. Now, if we talk about the very high-risk patients, we know that Caucasians are more risks than those with darker skin types, but one of the main risk factors are people with reduced immune systems, and transplant patients is the one target population that we focus on. So patients who receive kidney, lungs, hearts, or liver transplants have to take medications to prevent rejection of that organ because it's not their own tissue, it's someone else's. And this calms down their immune system so that it doesn't reject their organ, but it also increases the risk of long-term side effects. And one of the most common side effects of being on these medications for many, many years, especially now that they're living longer and longer and longer, is cancer and skin cancer. So they have almost 100 times higher chance of developing skin cancer compared to someone who's not on those medications. And about half of them will develop skin cancer at some point after their transplantation. With Australians, where there's a lot of sun exposure, After heart transplant, which is a big ordeal, you're getting someone else's heart, 1 in 4 patients who die after they survive for a year will die of skin cancer, which is a shock. I was surprised at that, and that is a shocking figure. And it's less in Canada and other countries where skin cancer is not as much a problem, but it's still a major problem. So as transplant patients survive longer and we preserve their transplanted organ in a much better way, we have to start dealing with the long-term side effects of their medications. So just to illustrate this, I received an email 2 years ago from a transplant patient's sister, and I'll just read it to you. So she said, skin cancer has been, in recent years, the most physically and emotionally debilitating aspect of her condition. And this was a patient who had a kidney transplant 15 years earlier and was doing fine in terms of the organ, but she was starting to deal with other side effects. And she said, my sister has had so many skin lesions removed that she feels as though she's being mutilated every time she has to endure another surgery. And my concern relates purely to my sister's emotional well-being and quality of life. And she went on to describe a gap in care that currently exists and that they are experiencing. So she said that her sister is so discouraged trying to find the right situation where she can feel secure. There seems to be no medical professionals working together. The oncologist or the cancer specialist defer to the skin specialist, and this is when they're talking about skin cancer. The skin specialist then defer to the transplant specialist, and then they all refer in the end to the surgeon who's going to remove the tumor. And no one is able to view the whole picture and put everything together. So the way things conventionally work when we look after transplant patients is clearly the main doctor is the transplant physician, the one who looks after their kidney or their lung, whatever organ was transplanted. And that's their primary responsibility. We then have the dermatologist who gets involved at various points, usually when they happen to see a skin bump or a rash, then they're referred over. If it is suspected to be a cancer, most of the time the dermatologist then refers to a surgeon who will then remove the tumor, and that's the primary treatment. Now, communication between these individual silos is not always optimal. If you look at the pathway here, the surgeon is being referred, the patient's being referred to the surgeon by the dermatologist. So really the surgeon will send a letter back to the dermatologist, not necessarily to the transplant physician. So over time, the transplant team, the primary caregiver, is not always made aware of skin cancers that come up, especially if they're coming up every week or every month. So there's clearly a demand from patients and from innovative healthcare providers, such as our program, for novel solutions to this gap in care. And so just to end off the letter, they were saying we're desperately trying to find a dermatologist who deals with skin cancers and anti-rejection medications in transplant patients, and they came across our website and thought that our center might be able to help. So what are we doing now to try to address this gap in care for solid organ transplant recipients? Well, if we look at these individual silos, we've now merged the two roles of a dermatologist and the surgeon into the Mohs surgeon, so myself and 2 others who work in the Mohs Center. So there's no longer this referral out to another surgeon and with discontinuity of care for the patient. We also, as Mohs surgeons, have additional training in caring for transplant patients. So we not only specialize in skin cancer, but we also have familiarity with the anti-rejection medications and the whole picture in caring for these patients. The other thing we've done is we've integrated our records with the transplant program so that we're able to share charts. It enhances communication. I often get phone calls or emails from the transplant team because they know who we are, and they can easily ask questions about, how serious was this skin cancer last week? Do I need to be worried? Do I need to lower their dosages of medications? Or is this something that, at this stage we can just hold tight? And so it fosters useful communication with the transplant team as well. And I think in the end, the patient really benefits. They have rapid access to us. We know that they're a priority, whereas in the community or elsewhere, they may not be seen as a priority patient to get in. And there's a shortage of dermatologists. Wait lists are up to 2 years. In Kingston, for example, it's insane. Your skin problems are probably self-resolved by then, hopefully. Or but that's a very, very long time. So our 3 pillars of care for these patients is really firstly prevention. So we want to get to educating the transplant team and to the transplant patients early on before they start developing problems. This involves education about sun prevention, looking at their own skin, and sun exposure. Next, we want to make sure that if they do get skin cancers, that we detect them early, and this involves screening them at least once a year, but depending on the risk factors, I sometimes see patients every month, and they're getting new tumors every month. Other patients actually can stretch it out to every 2 to 3 years if they're deemed to be very low risk. And then when if they do start getting tumors, we want to treat them aggressively, and we're able to facilitate rapid access to Mohs surgery to remove the tumors and make that a priority. And I'll be discussing Mohs surgery in a few minutes. It allows us to achieve the highest cure rates as well. And this is done in collaboration with the patient, with the transplant team, and if they have a local dermatologist as well. One of our focuses is really to integrate the understanding and the bridge between transplant care and skin care, and they're not individual silos. So when we talked about anti-rejection medications, you need enough medication to calm down the immune system to prevent organ rejection. But what you have to balance that with is the higher the dose, the more skin cancer you get. So it's a fine balance, and that's why the 2 specialties, the 2 disciplines, really need to communicate well with each other. So if you're over-immunosuppressed, your transplanted organ will do fine, but you'll get more infections and you'll get more skin cancers. On the other hand, if you reduce the dosage and it's not enough, then you'll lose your organ, which is definitely not a good thing. And although even despite your skin cancer risk being lower, the priority still in the end is preserving your organ. So we really, through communication and discussions with the patient, need to find this fine balance. And it's not always easy. I mean, the patients have a huge say in this. I had one lady in her 40s who developed a very aggressive type of skin cancer where the survival, 1-year survival is like less than 50%. And it had already spread to her lymph glands, so it was on her face and it spread to her lymph glands, so clearly even worse prognosis. And she had a kidney transplant, so if you don't have a kidney that works, you can receive dialysis. So at least there's a machine that can function for you, whereas for hearts or lungs, you can't go. If you lose your organ, there's nothing left to support those organs. So in discussion with her, the treatment really was, we have to stop all your anti-rejection medications because that's feeding the tumor, and if you want any chance of getting rid of the tumor potentially, we really have to stop all medications. And knowing that your kidney will likely be lost in the next 6 months, but you can end up back on dialysis. But as a medical professional, that seems like an easy decision to me. Your prognosis is bad, and we need to do this. But the patient said, I would rather die than go back on dialysis. So she actually ended up not wanting to reduce any of her medication. So I mentioned this example only to illustrate that it's a complex decision. Clearly the patient perspectives need to be taken into account along with the transplant team and the physicians, but it can be very challenging. So the Transplant Dermatology program here is really the only specialized program in dermatology focusing on transplant patients in Ontario, and one of the few in Canada. I did my training at Mayo Clinic, which was one of the pioneers and founded this concept actually previously in the States. But even in the U.S., there are not many of these clinics available. And as I mentioned, we're able to provide continuity of care for the patient. They don't have to see a separate surgeon, a separate dermatologist. We have collaboration and shared records for communication with the transplant team. And having this, for me in particular as a scientist, really facilitates innovative research. And so some of the questions have been derived from observations in the clinic. So we do notice that some transplant patients develop more skin cancers than others for some reason, and it's important to be able to identify who those highest risk patients are. And so, for example, what is the optimal anti-rejection drug regimen to minimize cancer risk while still preserving their transplant organ? We noticed that some patients after transplant and after skin cancer have higher mortality and also have higher chances of getting other types of cancer. So our question is, if a patient starts getting skin cancer, is that a sign that they may be at high risk of getting, other like lung cancers later, or colon cancers? And should we then if someone starts getting skin cancer, start screening them more intensely after that? And we also know that skin cancer on average develops 7 years after transplant, but it depends on many factors, but on average 7 years. And so that's a lot of time where we should be able to intervene and try to prevent or delay the onset of these tumors. So I'm going to discuss Mohs surgeries at the Skin Surgery Center here at Women's College. Are there any questions about Transplant Dermatology Clinic?
Is this a term that was invented here at Women's College?
Transplant Dermatology? Oh, Mohs surgery?
Mohs surgery?
Mohs surgery, a lot of people, the first thing we think of, and this was my first thought, was that it's an acronym, but it's actually named after a surgeon. It's Sir Frederick Mohs in Wisconsin. So no, it wasn't derived from us. But it's a surgeon's last name. It's often misspelled with capital MOH as well, or with an apostrophe. Sure.
Arthritis patients are also immunosuppressed. What is their risk of transplant?
Yeah. So there are patients, other patients who take we wouldn't call them anti-rejection, but immunosuppressive medications as well, or the inherent nature of their disease, like HIV, makes them immunosuppressed. So those populations are also at increased risk, but it's not anywhere close to the 90 to 100 times higher risk. We're talking about more like five times the risk. So much less, and it's because they're not taking as high of a dose. They don't need as high of a dose.
Can you also tell us the two ladies you mentioned? The one whose sister wrote to you, did she wind up coming here?
She did. So yeah, she's. I've been seeing her for the last 2 years, and we've caught up with a lot of the tumors. I mean, things are getting a bit out of hand, so we've cleaned up a lot of her skin, and she's been quite happy actually. We've been able to stretch out her visits to once a year. So that's.
Is she Canadian or is she coming from further?
No, she's from Ontario. Okay. Yeah, so she's coming from not Toronto, but yeah.
And the other lady who decided she didn't really want to go on dialysis and would take a risk with her life.
Yeah.
Did she make it so far?
You know what? She hasn't come back to see me, so I'm. Yeah, after that visit, actually, she didn't come back. So I heard through her transplant physician that her final decision was not to do anything, but since I'm not really involved in her care anymore, I can't really go peek in her chart or anything to find out. But hopefully, miracles happen, but so hopefully she's doing okay, but yeah. So for skin cancer, so now we're outside of the transplant area. This is just for general skin cancer, or not general, but high-risk skin cancer. So this is a typical basal cell skin cancer, the most common type. You can see that it's fresh-colored, so it's not often easy to see it. But you do see a round bump there, and we describe it as pearly, because it's a bit shiny. So traditionally, if you were to go to have this removed by a surgeon, the traditional way is to kind of define what you think, what the doctor would define what they think the edge is, and then take a safety zone around it, usually 6 millimeters, 6 to 8 millimeters. And to cut that out, send it to the lab. You get a result in a couple weeks. You'd be stitched up right away. And then when you get the results, they may say, you didn't get it all out, or they may say you got it out. And so if they didn't get it all, then you'd have to be called back, and then you'd have to redo it and take a bigger piece. Now, depending on the location on the body, like if this is on the back, we can take, there's a lot of skin on the back, we can take a bigger piece. It does lead to a longer scar, but there's a lot of laxity, we can bring things together. The challenging thing is if it's on a sensitive area, like the face. You don't want to be cutting a big piece out. The real estate is expensive on your face, and so we need other more innovative options. The other issue is where exactly are the tumor edges in a lot of these lesions. I see thousands of these, and I'm still surprised at how extensive these can be. And the reason is we often can see what's on top of the skin as just the tip of an iceberg, and there's roots that kind of expand out underneath the skin. So just to give an example, this was one of my patients. I always draw on them before and then show them in the mirror, but this is what I thought the extent of the tumor was, that yellow dotted circle. And I thought, there's something funny kind of up here. I dotted it just because I thought maybe, but I didn't want to go there from the start because there's no need to take out a bigger piece than is necessary. But this is the extent of the tumor in the end. I used to show these pictures without putting a blob there, but I've learned that it's better to put a blob there. So that's missing skin there underneath that blob. And you can see it's going around her eye, right? So I would have never predicted that it would have been that big. If we had done the traditional way, we would have cut a decent-sized piece here, but we would have gotten the result in 2 weeks saying we didn't get it all. Then we'd have to go back, and I probably wouldn't have gotten it the second time either, because I would have never guessed that it was going all the way up there. So what we do is called Mohs micrographic surgery, and what it allows is for us to test it, to do a quick test right then and there, and get the result within an hour rather than 2 weeks, the traditional way. So what we do is so if that's the tumor in the middle, we cut a 1 millimeter outside what we think the edges are. So we cut that circle out, or we make that incision of a circle. We make nicks so that just to help us know where to go, and we take that off. So you can see there's some nicks left on the patient, but there's also a nick on the specimen, so I know I can match them up if I need to after. We then take that over to our preparation area, and we have that circular piece of tissue, cut it into 4. And then we're taking I like to think of this as a pie. So the tumor is the filling of a pie, and we're interested in the pie shell. We want to know if there's any filling breaking through the pie shell, because that means we didn't get all the way around and underneath it. And so we have to take that pie shell and flatten it into a flat piece of tissue, because then we can take thin slices of it to look at under the microscope. So we flattened it down, and we numbered the pieces, so we know exactly where. If we have to go back to the patient, we know where piece 1 would have gone. We add red and blue ink so that we know which way is left and right, up and down. And then we take thin microscopic slices of it and prepare it for the microscope. So you can see here under the microscope, and the surgeon looks at it under the microscope ourselves. We become more intimately familiar with the patient's tumor than anyone else ever is. And you can see there that brown is a bit of tumor under the microscope, and we know that's piece 1. So, and we can mark it out. It's in the middle of piece 1, and we know where our blue and red edges are. And so we go back to the patient, and then we see that we go back to quadrant 1, and we take a little bit more just where we know that it's positive. We take a little bit more, and we take that out, and then we repeat the processing again. And then in this case, there was a little bit more, so we take a little bit more, and then we do it again. And so you can see we're very targeted in taking out only as much tissue as we need to, rather than, the conventional way, if we got a report back in 2 weeks saying, well, you didn't get it all, we would have to go around the whole thing. Well, it would be stitched, but essentially we would have to go around the whole thing still and take more, because we didn't know exactly where it was still left behind. This is our key machine or piece of technology which allows us to process this tissue and do the quick test on it in an hour. This machine was, thanks to the foundation donors actually, and allowed us to double our volumes because we got a second machine. But this is where it's very cold inside. It freezes the tissue and makes it solid so that you can then slice it right away, and we don't have to wait a couple weeks for the result.